this is Blount's disease is one of my favorite topics. For a long period of time, I've been doing this. Now, Blount's disease is a disorder of proximal tibial growth plate, medially causing progressive varus, knee malalignment in children and adolescents. Mostly, it is associated with early onset walking, obesity, and African American children are more prone to it. And bilaterals are more common than unilateral. There are so many synonyms known by as Blount's disease is known, but we prefer to use the term Blount's disease. Some people use the terminology infantile tibia vera, but other terminologies I've just got them from the book, but I don't see anybody using that. Now, clinical features are a lot similar to physiological genuvarum. Many of these children are obese, and when they walk, they do have a lateral thrust on walking, as you can see in this picture. Now, what are the radiological features? There are some distinct radiological features which distinguish Blount's from a physiological genuvarum. One of them is varus angulation at the epiphyseal-metaphyseal junction. Now, widened irregular physeal line on the medial side. That is one of the very classical features. The medially sloped epiphysis is another feature. And prominent beaking of the medial metaphysis and lateral subluxation of the tibia. Now, when you put all these features together, you can reasonably assume that it is a Blount's disease. Differential diagnosis is physiological genuvarum, but many of the radiological features are not there, as you see in Blount's. Genuvarum associated with rickets, I don't think there will be much confusion about that. Skeletal dysplasias, again, there's not a lot of confusion. And post-infectious, I'm sure anybody can identify from the X-ray. Now, Blount's disease goes by various stages, as described by Langenskoil. Stage 1 to 2, where complete restoration is common. Stage 3 and 4, restoration is possible. There will be some amount of epiphyseal depression and growth plate, but the medial growth plate is still intact. Stage 5 and 6, most of the time, the medial growth plate is fused, and there's quite a lot of epiphyseal depression, articular depression. Now, the prognosis using the Langenskoil classification or staging is not very accurate for non-whites. He basically described in the Scandinavian population. Stages can occur in earlier in non-whites. Sometimes one stage, they can skip a stage and progress to stage 6 also. Worse in black girls. And we don't have much data on the Indian population. Now, treatment depends on what stage and age. So when you have stage 1 and 2 between ages of 2 and 3 years, I would prefer conservative treatment, provided the patient is less than 3 years of age. And in unilateral cases, there's almost nearly 100% success. But if it's a bilateral case, obese child, ligamentous laxity, late initiation of treatment after 3 years of age, there is a high risk of failure of conservative treatment. This is one of the cases from my professor, where it was treated conservatively with the brace. Now the question is whether you use daytime brace, nighttime brace, or 24 hours. The results have been same. Whether you use it 24 hours or nighttime or daytime, ultimately it's the same result. So I would prefer to use the brace while the child is walking. Makes a little more mechanical logic. Now, stage 1 and 2, more than 3 years, it's a metaphyseal corrective osteotomy and fixation, either with acute or gradual correction, external or internal fixation, and we prefer to overcorrect to 5 to 6 degrees of valgus. This is for a patient with stage 2, and one side is stage 3, metaphyseal osteotomy, and that's the end result. We overcorrected it to about 5 to 6 degrees of valgus, and this is before. And this is after the almost a normal looking gait. Now, acute corrections can be done in these early stages with the plaster alone, and you get a good correction. And if there is some undercorrection or overcorrection, you can wedge the plaster also. Stage 3. Corrective osteotomy, most of the time metaphyseal alone, and delay in surgery, there is a higher chance of recurrence. This is a child with stage 3. We did an arthrogram just to make sure that there is no articular depression, although it looked on X-ray by that way. Bilateral iliceroid frame fixation. Bilateral iliceroid frame fixation, and that is a correction that we achieved. Can also do acute correction with the KYS also, osteotomy and KYS. Stage 4 and 5, they are more serious. Facial arrest has already occurred, although not seen radiologically. Now we must understand that there are two deformities, metafacial and intraarticular, and treatment must be individualized. There is an epiphyseal or intraarticular deformity and a metafacial deformity. Now, less than 7 years, what is recommended is medial epiphysealosis and interposition material plus or minus metafacial osteotomy. But many of these patients present more than 7 years of age. So epiphysealosis is by and large ineffective, and intraarticular osteotomy and elevation is recommended. This is a girl with stage 4 disease. We did the arthrogram, medial articular depression, intraarticular osteotomy, elevation, and fibula strut graph. And the metafacial varus deformity is now rather obvious. And stage 2, after 8 weeks, iliceroid frame to correct the metafacial deformity. And that is after the correction. And now she is walking with the frame on. This is the end result. Stage 6 is really bad. It's medial bony bridge and epiphyseal closure. And deformity will progress as long as the growth continues. Now there are definitely two deformities, intraarticular and extraarticular, and will need two osteotomies, intraarticular osteotomy and a metafacial osteotomy. And I would prefer to do it in stages. Now this is an 11-year-old girl, previously operated at 7 years of age with only metafacial osteotomy. We don't know what stage she was at that time when she had the procedure at 7 years. Now this is her picture. This is her gait. There is some amount of internal rotation also, especially on the right side. That is the X-ray, stress views. The epiphyseal depression is there, and the metafacial varus. We measured the procurvatum. It was an oblique plane deformity on the right. So we don't know whether there was a rotational deformity. We took a CT scan, not for the rotational deformity, just to see the intraarticular deformity. The step 1 was intraarticular correction on both sides and screw fixation and fibula strut grafting just to hold the osteotomy in place. Now we have a varus deformity on the right and an oblique plane deformity on the left. Iliceroid frame fitted for the metafacial deformity. On the left side for the oblique plane deformity. The correction started. Now, when the angular deformity was corrected, the internal rotation deformity was obvious on the right side. So we did a rotational correction, and you can see the amount of translation that has occurred, which is nearly 100%. This is the full correction and patient walking with the frame on. That is the pre-ring removal X-rays. This is after ring removal. The mechanical axis is restored, although there is a zigzagging. This is the initial deformity. And that's it after correction. 6 years later, follow-up. Almost the bone is remodeled so pretty well. Mechanical axis is restored. This is a normal gait. Iliceroid is not the only option. You can use an internal fixation, but the problem is you cannot do further adjustments after the surgery. There might be a risk of under or over correction, but sometimes things can turn a little nasty with danger of compartment syndrome and infection with internal fixation, especially acute corrections. Wrap osteotomy is a good procedure in the early stages. A single oblique plane cut allows simultaneous correction of varus and internal rotation. And you can do some post-operative wedging also to obtain the appropriate position. Guided growth, I have not much experience with it. This is from my teacher. provided for, you can do it for mild to moderate deformity, at least 2 years of growth remaining, and limited LLD, and as long as the patient is not too heavy. MRI, you don't really need an MRI. Some people say that you need to for the medial growth plate status or the medial articular depression, but all these can be seen well with an X-ray or an arthrogram. And again, you need the assistance of a radiologist to interpret the MRI. And both the cases anyway need sedation or anesthesia. So summary, especially after stage 3, consider the possibility of intra-articular deformity. An arthrogram is probably one of the very invaluable investigations to define the intra-articular deformity. After correction of the intra-articular deformity, assess the location and magnitude of the metaphyseal deformity, decide on acute correction, gradual correction, internal fixation, external fixation, and acute correction, keep in mind the compartment syndrome, over and under correction. Now, don't be terrified of a grotesque deformity. Keep the patella straight and the deformity becomes clear. Clinically examine the patient, proper X-rays, do malalignment tests, locate the chora and choras, CT, MRI if needed. Decide what your correction is going to be, acute or gradual, internal or external fixation. Decide your implant. Again, the most important thing, spend time with the patient and the parents, discuss pros and cons. Thank you.